Okay, friends, welcome to another SEVA VentRounds. I'm your host, Rob Chatburn. Dr. Mireles is not here today, and our case today is called Take Off the Handcuffs. So, we can get to the next slide. Here we go. As always, we have our disclosures. We don't endorse any mode, manufacturer, or company. Whatever we say is our opinion, and it does not represent the Cleveland Clinics. These are the conflict of interest for Dr. Mireles and myself, and today is joining us with Mr. Ariel Garnero with his case presentation. So, next slide. Ground rules. This is a recorded session. Please keep your microphone muted until you want to say something so we don't get any background noises. We may call upon you, or you can certainly raise your hand or put something in the chat, and we will try to respond to your questions. There are CERCEs for respiratory therapists, and we'll give you a code at the end of the presentation where you can go to that and get your credits. The evaluation must be completed within an hour to receive your credit. Okay, as always, we start off with a little bit of theory. And today we're going to talk about inspiratory times, and there are at least two different inspiratory times of interest. The one that we're most familiar with is shown here in green. This is a airway pressure waveform from a ventilator in pressure control mode. And we see that the interval from C to D, or the interval of C, is the inspiratory time. So we see the patient has triggered the ventilator here. We have an inspiratory time in green. And then the pressure goes down to baseline, and that's the expiratory time shown in D. However, in the background, in this red line, we have the PMUS signal, because this is a waveform taken from a simulator, not from a ventilator, of course. And we see that the start of inspiration is here, and in the interval A, the inspiratory muscle pressure is increasing. It's shown negative here, but it's actually a positive number. So as the inspiratory effort increases, then we call that the neural inspiratory time to the peak, and then it relaxes and goes to 0. And for the period indicated here as B is the neural expiratory time. So obviously there's a mismatch here between the neural inspiratory time in A and the set ventilator inspiratory time shown in C. And this is where the problems arise. Now, as I said, you can't see PMUS on the ventilator waveform directly, but you can detect it in the pressure or flow waveform, depending on what kind of mode you're in. So in volume control on the left here, we see the normal passive pressure and flow waveforms. Here we have a constant inspiratory flow, and the pressure waveform is undistorted. But on the right, again in red, we see in the background the patient making an inspiratory effort, and it distorts the pressure waveform. So as we say all the time, if you are in volume control, you look for the pressure waveform for the distortion due to PMUS. And where do you look for pressure control? Well, in pressure control, we want to see a constant inspiratory pressure usually for set point targeting, and we have an exponential decay in the flow for passive inspiration. But here again, if we have an inspiratory effort midway through the inspiratory time, then we're going to distort the flow waveform. We've gone over this many times, and now we're going to see how this applies in an actual case study. All right, I'm going to turn it over to Ariel Garnero. These were some screenshots that he made on an actual patient. And we're going to start off as usual, identifying the tag. So go ahead, Ariel.
Thank you, Rob. Good afternoon to everybody. This is a real case that I ventilated, I don't know when, but in this screen, I put on the right conditions when the patient was totally passive. And you can find on the left the conditions when the patient when we see some sort of activity. So as Rob mentioned, let's start with the tag, followed by the load, and later on by any PV discordance. Feel free to put the tag in the chat section. see if I can see the chat.
Yeah, I can't see the chat, Ariel, so you're going to have to do it.
I'm looking at it. This is a Hamilton C6. Fernando put very well the tag. I don't know if anybody else wants to take a chance. Mike also did it right. The commercial name of SCMV in this machine is the mode that the control variable is volume control. The mode is composed of mandatory breaths, so the breath sequence is going to be CMV, and the targeting scheme is set point, meaning that whatever we set is going to be the same on every single breath. So now I don't know if anybody wants to describe what's the load. Remember, it's going to be elastic, resistive, or P-mask.
Let's start with inspiration first.
Okay.
Here's it. Here's the inspiratory time here. What's going on here? Go.
Yeah. Lee very well pointing that there is P-mask. Same as Fernando. And I think the point that we need to address at this point, if P-mask is the consequence of something else, if it's something that the patient is doing on purpose, or is the consequence of something else. And that comes when we need to analyze the trigger.
Okay, we'll get there in a minute. But just to point out that on the right here is a passive patient for reference.
Yes, in the passive patient, it's very important you can analyze the load because you got the mechanics under passive conditions.
Okay, so what do we see during expiratory time? What's the load there?
Nobody is answering during expiration, but
So this is the expiratory time here, right?
yeah, they are mentioning also the presence of P-mask.
Yep. That's it.
Okay, so concerning the PD discordance, what do you guys think is going on during the trigger phase? Is it the trigger normal, early, late, false, failed?
There we go. Fernando.
Yes, Michael and Fernando, they both said early trigger, and they are right. And the key point here is to identify who is triggering the mandatory breath. Is it the machine or the patient? In this one, the C6, we usually see a triangle, the same color of the trigger variable when the patient is triggering, and we don't see anyone here. That means that the breaths are mandatory breaths triggered by the machine only. And they are followed by some sort of inspiratory muscle activity, which perfectly fits on the early triggering definition. The P-mask comes after the P-vent. In a few words, the machine is triggering before P-mask.
Okay, so moving on to inspiration now. Is this a case of what you would call normal or acceptable assistance? Is it over assistance or is it under assistance? Looking at inspiration. Okay, we have one over, one under.
So
Go ahead, Ariel. What do you think?
I think that in this case, if we see that the pressure is going down, means that the vent is doing less pressure. If we compare to the picture on the right, where the PIP was 34 under passive conditions, That means that P-vent was doing all the work necessary to overcome the elastic and the resistive load. When we go to the right, we can see the PIP of 19, which means that the vent is doing less work, and some of that work is being done now by the patient.
Right. And so the question is that if it was over assistance, what would we see if it was over assistance? The ventilator is doing too much work, more than the patient needs. What would we see there?
Rob, can the vent do more than 100% of the work of breathing?
No. But
So that's what we have
that's
on the
true.
picture on the right.
Yeah, that's the picture on the right. That's full. And you might argue, depending on the clinical situation, that it's over assistance because the patient's not making any inspiratory effort. Why not? Maybe because his CO2 is too low. That would be over assistance, right? So in this case, we see work shifting, but it's not severe because the airway pressure isn't dropped below baseline, and it's not even halfway. So I would say that's probably an acceptable level of assistance at this point. Would you agree, Ari?
Yes, and concerning what you say, maybe the respiratory rate is playing a role here in a possible over assistance.
There you go. It depends on the clinical scenario, right?
Yes.
So in this situation, we have said before, this reverse triggering or early triggering often happens when there's over sedation, right?
Yes.
And
It's
what
related.
what would you do to fix it if that's the only thing you were concerned about?
Well, in this case, and depending on the clinical scenario on the gases, we can either attempt to decrease the respiratory rate, or the approach I was taking after that was switching the mode, which we're going to evaluate when we go to the next picture.
Right, we'll get to that. Okay, so let's now talk about cycling. What's going on there with cycling? Normal, early, or late? What do you guys think? Well, what do you say, Ari? Where do we look?
So far, they are saying somebody said normal, and considering the cycling, we can see that clearly there is something weird during expiration. There is some sort of scoop on the expiratory, on the peak expiratory flow rate, which means that maybe something that happened due to the machine trigger is extending, passing the mechanical inspiratory time. In a few words, it looks like the neural inspiratory time of the reversely triggered breath extend beyond the mechanical inspiratory time and halfway into the expiratory time.
Yep, there's your neural inspiratory time.
Yes. So, Rob, when this late cycle is caused because of early triggering, is it still considered early cycle?
I would say that this is an early cycle caused by an early trigger, right?
Yes.
And we say it in that order because which one would you treat? Would you try to fix the early cycle by, say, prolonging the inspiratory time? Or would you fix the early trigger by, as you mentioned before, dropping the respiratory rate and see if the patient can start triggering?
Anytime this kind of interaction is not nice, because it can cause some sort of plyometric contractions on the diaphragm. I mean, when the diaphragm is trying to, when the vent is producing exhalation, the diaphragm is still contracting.
That's right. So this type of synchrony could cause problems, right?
Yes.
All right. And so in expiration, well, we pretty much just mentioned what's happening in expiration. The expiratory flow is being distorted. Someone might say, well, right here, is that, a failed trigger effort? Well, probably not. It's more likely just the continuation of the inspiratory effort from inspiration into expiration. So it's not, it wouldn't call it a failed trigger effort. We'd call it, you know, an early cycle, right?
Yeah. Should we consider this slide terminated so we can go to the next one?
We can do that.
Yes. So somebody tried to make to try to improve the situation and decided to change the mode from BCCMBS. A new mode was chosen that, and if you guys can name the tag of this mode on the Hamilton C6, which commercial name is APV-CMB.
So first of all, think about what gets the control variable, right? And then whether these are all mandatory breaths or all spontaneous breaths or what's going on here.
Something that we can observe is that we don't have the square or rectangular waveform that was preset on a volume control mode. Now we can see the inspiratory flow shapes are quite variable, which is a characteristic of any pressure control mode where the flow is free to assume, the flow waveform is free to assume any flow shape. And as Rob is pointing out now, when the patient is passive, the flow from the initial peak inspiratory flow decays exponentially.
So let's get into the tag before we run out of time here. What's the tag for us, Ari?
Okay, the tag, the control variable is pressure control. Fernando put very well, the CMB is the breath sequence, but the targeting scheme is adaptive, which means that we say that target tidal volume and the machine will try to adjust the pressure, trying to deliver the target tidal volume.
That's what the A and the APV means, right?
Yes. So just to make it a little bit faster, we can see compared to the previous screen, I was there, I could see less, the patient was working less when we switched the control variable from volume control with a preset flow, and I liberated the flow by switching to a pressure control mode. But this mode is still composed of mandatory breaths. There is a set inspiratory time, and we can observe that still we have conflicts between the mechanical inspiratory time and the neural inspiratory time. In a few words,
so you took off one of the handcuffs, but not the other one, right?
Yes. In a few words, we can observe that the early triggering is still present. By switching the modes, we make a little improvement, and I can witness that because I was present there, but still we have the problem of the early triggering or reverse triggering.
Next slide.
So the most logical step that we can take after releasing the flow is also why not switching the mode to a more spontaneous mode where the patient we can remove the respiratory rate and the patient can decide his or her own respiratory rate, and we also liberate the inspiratory time. So you can go to the next one, Rob. What do you guys think is the tag on this mode? The commercial name is PSIMB plus, which we usually associate with pressure SIMB. This then, the Hamilton C6, has in the option panel an option called P-Sync that when activated, it changed the mode from being an IMB type 1 to an IMB type 2. I don't know if you, Rob, can describe the differences between IMB type 1 and type 2?
Yes, type 1 is the original type, whereby you set a mandatory breath rate and you're going to get that rate no matter what the patient does. IMV type 2 lets the ventilator look at the spontaneous breath rate, and if that spontaneous breath rate is higher than the set mandatory rate, then it will not deliver mandatory breaths. The mandatory breaths are suppressed by a high spontaneous breath rate. And the reason why you want to do that is You want to get the mandatory breaths out of the way if you don't need them, because the patient will have better control over the timing with spontaneous.
Yes. So people can argue that this mode, we cannot differentiate if it is IMB type 1 from IMB type 2 at this time. But I can tell you that, as Rob mentioned, when the respiratory rate is increased, the set rate is 12, you can see that the observed respiratory rate is 17. That means that at this time, all the breaths we observe are spontaneous ones. They look pretty much alike, but all the mandatory breaths, they are abolished. And that means that we improve the situation by liberating the flow rate and also by liberating the inspiratory time to a variable inspiratory time, which serves the goal of comfort and also safety because we don't have any more the early trigger.
Also on this ventilator, another hint is that it says delta P instead of inspiratory pressure, or right?
Yes, in SIMB and the regular SIMB, we usually have two control from the mandatory and another one from the pressure supported breath, the spontaneous breaths.
Right.
So
now you only have one. Yeah.
This mode and this option, sadly, the manufacturer doesn't change the commercial name. So many people can be tricked thinking that this is the popular pressure SIMB or pressure control IMB type 1.
Okay,
that's why the type.
So Lee
Yes,
asked, why did you pick this versus PCCMV or PCCSV?
Because first, I wanted to serve the goal of safety by having such a backup respiratory rate. At this point, this mode, as any typical IMD type 2, joins two modes together, a mandatory and a spontaneous mode. So the mandatory is going to kick in case there is any kind of apnea. At this present time, the mode is functionally working as a pressure support. There's no way you can distinguish an image from pressure support that PCIMB type 2SS working on the side of pressure support. Only when the patient becomes apneic, as it's going to be seen on the next slide, we can see how the mandatory breaths are reintroduced. So a pressure support option would have been also nice at this present time. So
but you wouldn't get the goal of safety in there as well. And this is most commonly seen, at least in our institution, on servo ventilators because it's called auto mode.
Yes, this is a version. This mode is the equivalent to auto mode pressure control, pressure support on the servo U, and it's the equivalent on the V60 of the BiPAP ST as well as on the Nihon column. BiPAP ST has the same kind of tag, IMB type 2 SS. So this final slide is a representation of how the addition of P-Syncs turns IMB type 1 on IMB type 2. Here I'm working on playing on the simulator and I'm activating the pressure supports. So you can see all the ones with the triangle, they are pressure supported breath. And suddenly I stop triggering and you can see how the mandatory breaths are reintroduced to serve the goal of safety. The goal of safety is served by guaranteeing a minimal respiratory rate. But the goal, the main intention of this mode is to transfer the patient automatically from mandatory to spontaneous breath, so we can remove the inspiratory time in favor of a variable inspiratory time. So we serve the goal of comfort and safety at the same time.
Michael points out that that the switch from mandatory to spontaneous breaths is probably based on the cycle time, or the time between the last mandatory and the first spontaneous.
We can call,
the point is that it's the same as saying it's the higher frequency, right? Because frequency is 1 over the cycle time. So if the frequency goes up, the cycle time goes down and vice versa. So it's just two ways of looking at the same thing. The ventilator doesn't sit there and wait for a whole minute to say, oh yeah, the patient's breathing faster spontaneously. It just does it, as he points out, based on a single cycle time.
Yeah, so what the machine does, after every single breath triggered by the machine activates a waiting time period. On this kind of mode, the waiting time period is the total cycle time, which is 60 divided by the respiratory rate. In this way, in this mode, the respiratory rate observed is never going to be less than the set. And that's why it's different from auto-mode pressure control, pressure support, when we discovered in the article we published that we can observe a lower respiratory rate than the mandatory set rate as a form of unintentional hypoventilation. So this mode, in a few words, has more safety features than auto-mode pressure control, pressure support.
Very good. We're just about a minute away from closing. Does anybody have any questions? Any other comments? Well, here's some take-home messages. Ari, you want to go through these for us?
Yeah. Usually, when we set the inspectory time, we set arbitrarily, and it's always going to be the same time. It's going to be the same monotonous time versus the neural inspectory time, which is highly variable. And a spontaneous breath, its definition, it has to be a breath triggered and cycled by the machine. Any machine involvement makes the breath a mandatory one. And lastly, spontaneous breath are the most synchronous because the patient controls when they start and when they finish. And also, there's, in a few words, nobody's deciding when they start. There's no set variation in the flow rate, and nobody's saying when they finish. Everything is under the control of the patient.
Very good. Well, thank you all for joining us again this week. And these will be recorded, and these are your QR codes for getting your credits. And thank you, Ariel, for joining us, and we'll see you next time.